All right, let's dive in. Have you ever wondered how doctors can look at someone who's short of breath and figure out exactly what's going on inside their lungs? Well, that's what we're doing today. We're going to crack the code on pulmonary function tests, or PFTs, and turn what looks like a bunch of complicated numbers into a story that makes perfect sense.
You know, when you strip it all down, this whole complex diagnostic mystery really boils down to one single question. Is the problem getting the old, stale air out, or is the problem getting new, fresh air in? Seriously, that's it. The answer to that one question decides which path we go down.
And that brings us to our two main suspects. On one hand, you've got obstructive disease. I want you to think of this as the floppy lung problem. The lungs are kind of stretched out and overinflated, but the airways are blocked so you can't get that old air out. It's trapped. On the other hand, you have restrictive disease. This is the stiff lung problem. The lungs are fibrotic, they're rigid, and they just can't expand enough to pull in a good deep breath.
So, here's our game plan for this investigation. First, we'll get to know these two types of lungs. Then, we'll hunt for clues in the lung volumes. After that comes the big one, the decisive spirometry test. Then we'll refine our diagnosis with some more advanced clues, and finally we'll put it all together and crack the case.
Okay, let's kick off our investigation, a tale of two lungs.
The main thing to remember is that PFTs aren't just one test. Nope, think of them as a detective's toolkit, a whole collection of tests designed with one big mission: figure out if we're dealing with something obstructive, something restrictive, or something else.
All right, first things first, our initial clues come from measuring things. We're going to size up the problem by looking at the lung volumes, and this gives us our first major hint about which direction to look.
And what's really cool here is how intuitive this is, right? In obstructive diseases, all that air gets trapped, so the lungs basically become these big, overinflated balloons. So naturally, the total lung capacity, or TLC, and all that leftover air, the residual volume, are all going to be increased. But for restrictive diseases, the lungs are tiny and stiff. So, you guessed it, all those same volumes are decreased. It's our first clear piece of evidence.
Now, looking at a table of numbers is one thing, but how about a picture? The first really powerful visual clue we get is called the flow volume loop. It's basically a snapshot, a single picture of one full breath.
And this graph just beautifully shows the difference. For an obstructive disease, with all that trapped air, the entire loop gets shifted way over to the left. You can literally see that huge residual volume. But for a restrictive disease, the lungs are so small, the whole loop is shrunken down and pushed to the right. Just a glance at this graph, and you're already getting a pretty good idea of what's going on.
Okay, so we've gathered some solid initial clues. But now it's time for the main event, the test that usually blows the case wide open. This is forced spirometry, the Mac Daddy of all PFTs. So, the first key piece of data we get from this is the FEV1. This one is all about speed and power. How much air can you blast out of your lungs in that critical first second?
And the second key number is the FVC, or forced vital capacity. This one isn't about speed, it's about total volume. After you take the deepest breath you possibly can, how much air can you blow out in total?
So how do these two numbers help us? Well, here's the absolute key. In obstructive disease, the biggest problem is getting air out quickly, because the pipes are blocked, right? So the FEV1, it takes a nosedive. In restrictive disease, the problem is that the total lung volume is just small from the get-go, so the FVC is what's really, really low.
So, how do we put these two numbers together to get our definitive answer? Well, it all comes down to a simple ratio and one magic number, less than 70%.
This is the smoking gun. You take that FEV1, you divide it by the FVC, and if that ratio is less than 70%, boom, that is the hallmark of obstructive lung disease. Why? Because that initial blast of air, the FEV1, drops so much more than the total volume. With restrictive disease, yeah, both numbers might be low, but the ratio usually stays normal. This ratio is what cracks the case.
Okay, so we've identified our main culprit. Let's say the ratio was low, so we know it's an obstructive disease. But our job isn't done yet. Now we have to follow the clues to figure out exactly which kind it is. And the next question is pretty straightforward. Is this obstruction something we can reverse, like you see in asthma, or is it a more permanent, irreversible problem like in COPD?
And to answer that, we do the bronchodilator test. It's a really simple but really smart experiment. We measure the FEV1, then we give the patient a puff from an inhaler to open up their airways. We wait a bit, and then we measure it again. If that FEV1 number gets better by more than 12%, it tells us the airways are reactive and the problem is reversible. That points us straight to asthma. If it doesn't change much, that suggests it's a fixed problem, like COPD.
Okay, let's go one level deeper. To really sharpen our diagnosis, we can use the DLCO test. Now, this test doesn't just look at air moving in and out. It looks at the lung's actual efficiency. How good is it at its main job? Getting gas from the air sacs into the blood. This is a really crucial piece of the puzzle.
And this table just lays it all out for us. The DLCO result helps us get so much more specific. For instance, if we already know it's COPD, a low DLCO points to emphysema because the actual surface of the lung has been destroyed. But a normal DLCO? That points more to chronic bronchitis. And for restrictive diseases, a low DLCO tells us the problem is in the lung tissue itself, but a normal DLCO suggests the problem is outside the lung, like an issue with the chest wall. It's an incredibly powerful test.
All right, we've gathered all our evidence from the lung volumes, the spirometry, the diffusion tests. It's time for the grand finale. Let's put everything together into one clear diagnostic map.
So here it is, the complete algorithm for an obstructive disease. Step 1. Your FEV1/FVC ratio is less than 70%. Step 2. You confirm it with those big lung volumes. Step 3. You use the bronchodilator test to tell asthma and COPD apart. And step 4, if it's COPD, the DLCO test separates emphysema from chronic bronchitis. See? Each step just flows logically into the next.
And the path for restrictive disease is just as logical, maybe even a little simpler. You start with a normal or high ratio. You confirm it with small lung volumes. And then you use that DLCO test to figure out if the problem is inside the lung itself or coming from somewhere outside. It's just a beautifully complete system. So there you have it. What started out as just a bunch of confusing numbers and squiggly lines is now a clear story. PFTs aren't just data points. They are the language of the lungs. And now that you know the grammar, now that you know the vocabulary, you can read that story too. So the only question left is, what tale do they tell?